Good evening, everyone. On behalf of TaskMate, I would like to welcome you all to Medcast, Insights into Healthcare, a learning initiative by TaskMate. Today, it's a great pleasure to have with us Dr. Sanjeev Mittal, who is a consultant cardiologist and director at Sanjeev Heart Center, Ludhiana, Punjab. We welcome you, sir. Sir, we look
Thank you.
forward. Thank you. We look forward to hear from you on today's topic of discussion, Mexiletine, an unexplored antiarrhythmic drug. Over to you, Dr. Mittal.
Yeah, thank you, Neha. Thank you for your kind words.
Thank you.
Today is a very interesting topic. Actually, we will be talking about ventricular tachycardia, and there is a this is one of the and we will be talking about the role of mexiletine and for an unexplored antiarrhythmic drug. So this is a very new drug. I think very few physicians might be knowing their name. In fact. And so we'll be talking about the ventricular tachycardia in detail and a few words about the mexiletine. So I'll be starting my talk with a small case history. She was a 56-year-old woman. She presented to me with palpitations and breathlessness for the past 2 days. The ECG showed wide QRS tachycardia, and there were no comorbidities as such. So a 56-year-old woman presented with palpitation, breathlessness, and an ECG wide QRS tachycardia. Now, this is a basic teaching in our DM and in my MD that anything, if there is a wide QRS tachycardia, it is a ventricular tachycardia until proven otherwise. So that is one of the basic teaching in the in our DM days. So any wide QRS tachycardia is to be considered as a ventricular tachycardia. Now over here you can see the ECG of that woman with the history of sudden onset palpitations. You can see that there are a wide QRS complexes, and you can see at some places there are a P wave which is following the QRS, but it is not following any pattern. So actually when the P is not related with the QRS, then we call it as AV dissociation. Now there are so many causes of AV dissociation, but the mainly thing is the ventricular tachycardia, and one is always a complete heart block. So when the P is not related to the QRS complex, and then we call it as AV dissociation. So anything, if the tachycardia is there, it is wide QRS, and an AV dissociation, it is 100% is a ventricular tachycardia. Okay, so you can see that is a wide QRS tachycardia with an LVP type of morphology with a right axis deviation. Normally, what we have seen is a normal axis or a left axis deviation, but if there is a right axis deviation, it is also suggestive of ventricular tachycardia with a AV dissociation, as I have already told you that the P waves are there which are following the QRS, but they are not following any pattern. So V is not related with the P wave, and that is why it is called as AV dissociation. That is the A. That is the A is basically the atrial wave or P wave. It is dissociated with the V, that is ventricular wave. So that we call it as an AV dissociation. Okay. So you can see these are the P waves, and now of course so many I think some of the doctors which have joined, they have worked in the ICU, and this is a very common arrhythmia, patient having ventricular tachycardia. So what do we do? So normally this is a traditional teaching that if the patient is hemodynamically stable, suppose the BP is stable, and then we can give IV amiodarone. IV cordron like amiodarone is given bolus. Whether normally we give 300 milligram of the bolus, 150 milligram of the bolus, followed by infusion. So normally this patient was given IV amiodarone, and after that the sinus rhythm was restored. Now over here you can see that there is a P wave and a QRS followed by QRS wave. So P wave followed by QRS, and it is sinus rhythm. So this is how the things is there. So this patient, the VT was reverted with IV amiodarone bolus. Okay. Now this is the usual treatment of the ventricular tachycardia of the BP stable, that is IV amiodarone bolus followed by infusion. But if there is a hemodynamic instability there, I would like to add you that then we have to give DC shock. DC cardioversion has to be given if the BP is unrecordable or BP is very low. But if the BP is stable, then you can give IV amiodarone. Now we did the echocardiography of this patient that revealed dilated cardiomyopathy with LV dysfunction, and usually we do angiography of this patient also, but angiography revealed normal coronaries. So this is a case of DCMP with LV dysfunction presented as ventricular tachycardia. Cardiac MRI is also done for this patient, which includes biventricular inflammatory cardiomyopathy with extensive fibrosis with an ejection fraction of 30%, and RV was also mildly impaired, which is usually seen in DCMP. So what is the impression? The normally impression is viral etiology. Now, especially, we are seeing a lot of cases of this thing, especially, in this corona, after this COVID virus, because we have seen a lot of patients with viral myocarditis. And in fact, there is one patient initially, the New Zealand, the post-vaccine, post-Pfizer Moderna vaccine, there was a, myocarditis and leading to the death of the patient. So this is very common, viral etiology, and even post vaccine, though it is a very rare, post vaccine, it is a very rare type of thing, 1 in million only, but yes, it is there. And then this patient was started on medical management, which included beta blockers and amiodarone. Remember, beta blockers is one of the important drugs for any type of tachyarrhythmias, and it is usually given whether it is supraventricular ventricular. Beta blocker is always the mainstay, but along with that, because there was a ventricular tachycardia, so we have to give amiodarone. Now, but the story doesn't end over here. This woman again developed, ventricular tachycardia. This time also, it was hemodynamically stable with a wide QRS complex. Over here, again, you can see that it was a right axis deviation with LBB type of morphology, and AV dissociation was there. So wide QRS tachycardia. Over here, now it is a RBB type of morphology. Okay, there is a prominent R wave in the V1. In previously it was like an LB morphology. Now it is an RB morphology with a right axis deviation, and AV dissociation was there. So with the wide QRS tachycardia. So wide QRS tachycardia with the AV dissociation is ventricular tachycardia. It is a short ventricular tachycardia. So again, this patient, now instead of giving amiodarone, we gave IV lidocaine, and IV lidocaine is also one of the useful drugs. And previously, you have seen in your, the previously IV lidocaine was one of the drug of choice, before the amiodarone came. And IV lidocaine, the patient reverted to the sinus rhythm, but this patient was again having repeated VT episodes. So we have to give, electric cardioversion was done with 100 joule of DC shock. And this patient was started on propranolol, oral amiodarone was continued. So the provisional diagnosis for this patient was acute myocarditis with the pleomorphic VT. Pleomorphic VT because initially it was in a LB morphology, the other time it was a RB morphology. So the morphology keep on changing. So when the morphology keep on changing morphology, then it is called as pleomorphic. So it is acute myocarditis with pleomorphic VT with LV dysfunction. So that was the full diagnosis for this patient. And now the problem, then we did the ECG again, and this showed that there was a QT prolongation. There is a QT prolongation, and as we know that amiodarone causes increase in the QT, so it also prolongs the QT. So if the patient is already having a prolonged QT, therefore we have to stop oral amiodarone. So oral amiodarone had to be stopped in this patient, and but this patient continued to have recurrent slow ongoing ventricular tachycardia. And then there is another option for ventricular tachycardia is a ventricular overdrive pacing with temporary pacing wire. So we do a temporary pacing, and then we whatever the rate of the ventricular tachycardia is there, we pace it at a higher rate. So once we pace it at a higher rate, then it will overdrive it, and then we suddenly stop the pacing, and the patient reverts back to the again the sinus rhythm. So that was done. And then there is also another thing which we can do, stresses epidural anesthesia with bupivacaine, that can be given, so the patient goes into deep sedation, and that can also revert or that can also abolish the VT at that time. But for this patient, both attempts were futile, and further there was a severe sinus bradycardia. Because we have given so many of the drugs, IV lidocaine, oral amiodarone were already there. This patient, in fact, developed severe sinus bradycardia at the rate of 30 per minute, which was in fact refractory to the atropine. What we normally do when there is a bradycardia, we try to give atropine, but this patient was in fact refractory to the atropine also. So what we did, we did a temporary atrial pacing was done via catheter in the coronary sinus. Then the other thing is which you can do is the catheter ablation was considered because the multiple VT morphologies, but it is found to be poor efficacy, so it was not right. Now, since the VT was ongoing, so periodic DC shocks were administered, That's why at that time we decided to start tablet Mexiletine, was added to this patient and followed by low dose of Madron. So over the next 3 days, the VT became infrequent. And after 48 hours of VT free period, and then we advised the patient to go for a dual chamber ICD, which was inserted for that. So Mexiletine, what happened is that this Mexiletine, that stabilized the patient, and the patient didn't require, multiple DC shocks afterwards, and then we can go for the ICD. We have to see that the ICD is to be inserted in only those patients who are not having recurrent VT. Otherwise, the battery will drain off very easily. So we have to actually, we have to make the patient that the VT is happening, infrequently only. But if it is happening frequently, then we have to do, something with the drugs. We have to adjust the drugs before the ICD could be inserted. So in this patient, Mexiletine was the drug which came to our rescue, and this VT was stabilized, and that's why this patient therefore was stabilized with Mexiletine, and his VT episodes decreased. Now with atrial pacing 70 per minute, optimal dose of amiodarone, beta blocker, and Mexiletine could also be given, and the patient was discharged in a stable condition. So you can see that we tried everything. We did amiodarone, we did lidurupane, we also did the overdrive pacing, etc. But in the end, it was Mexiletine which came to our rescue. Now we'll be talking about the VT storm. So what is a VT storm? This is called a ventricular tachycardia storm. Storm is like, you know about that. This storm, like the electricity, all over the sky. So the VT also happens over the heart like that. So that is called as VT storm. So what is the definition of VT storm? So this patient definitely, you can see that the patient was having multiple episodes of ventricular tachycardia. So that this patient was actually having a VT storm, in fact. And the definition of VT storm is that in patients without an ICD, the electric or VT storm is defined as 2 or more hemodynamically stable VT within 24 hours. So if the patient is having, stable ventricular tachycardia, 2 or more episodes in 24 hours. That is why, so if any of your patients come with palpitations or something like that thing, I think Holter 24-hour Holter is one of the important things which you should ask the patient to get it done. And I routinely do the Holter study, and Holter definitely detects something. It is able to detect ventricular, non-sustained ventricular tachycardias. It is able to detect atrial which beats, how many there, and whether the patient is having any stable VT or not. So electric storm is also defined by the 2 or more hemodynamically stable VT within 24 hours, and then the VT recurring soon after, that is within 5 minutes of the termination of another VT episode. Suppose the one VT episode happens, and after 5 minutes, the VT again happens. So then by definition, it becomes an electric storm. Then the sustained and non-sustained VT, resulting in a total number of ventricular ectopic beats greater than the sinus beat in 24-hour period. So that is what it is, that we do a Holter study over 24 hours, and you see that the ventricular ectopic beats are more than the sinus beats. Suppose the sinus beats are, that is, it is 50, then the ventricular beats are more than that. It is, the ratio is more than 1:1. So ventricular beats are more than the sinus beats. Then it is called as a electric storm, VT storm. And this was for the definition without an ICD, but the patients who are having an ICD, that is intracardiac defib already there. And the most widely accepted definition of electric storm is that 3 or more appropriate therapies for ventricular tachyarrhythmias, including antitachycardic pacing or shocks within 24 hours. So if we have to, if suppose there is ICD order in the patient, and this ICD gave shock to the patient about 3 times, or the patient have an antitachycardic pacing for more than 3 times, then it is called as VT storm. However, this definition is not comprehensive and fails to account for the VT that is stored in the program detection to the ICD, or VT that fails to terminate the ICD therapy. So these are a little bit of the more of a technical things. We'll go into that. And then what are the clinical symptoms of electric storm? So we have discussed that what is VT storm or electric storm. So why does it happen, and which clinical symptoms are associated with it? So the electric storm develops when a vulnerable anatomic substrate, such as that from a structural heart disease or scarring after an MI. So the most common cause which we found in our practice, in my practice, is what we see that the patient has a myocardial infarction, and after myocardial infarction, there is a scar formation happens, and so around that scar, actually, the VT happens. So this is the most important thing. That is the most important cause. That is a vulnerable anatomic substrate, which is a scarring after MI, or sometimes the structural heart disease is affected by a triggering event, such as a premature ventricular contraction or lateral imbalance. So this is an important thing. And the patient has a vulnerable substrate, and over that the patient does some suppose have a VPC comes, and after the VPC, this get a re-entrant type of tachycardia, and then the patient does VT. Or suppose the potassium is high or low, or magnesium is low, then also the patient can have ventricular tachycardia. So if the patient has a substrate, vulnerable substrate over and above, if a PVC does or some electrical imbalance is there, then this patient can go into electric storm. The other is that determining the cause of electric storm is always essential, because treatment must target the underlying mechanism. So that is an always important thing, whether it is due to a structural heart disease, or whether it is due to scarring after MI, or whether it is due to the PVC or electrical imbalance, because we have to treat it accordingly. You have seen in the ICU that we always try to check potassium levels and magnesium levels. If magnesium is low, we have to give max sulfate, and if the potassium is high, then we have to lower the potassium, or if low is there, then you have to supplement the potassium. So these are very important things if the patient is coming with electric storm. Now we will discuss something about the ventricular tachycardia, that what are the morphologies. Now the main type of ventricular tachycardias are basically 4 types of ventricular tachycardias are there. One is monomorphic. Monomorphic ventricular tachycardia is called when the QRS complexes are of the same morphology. एक ही तरह के जो हैं QRS complex होंगे. The other is a polymorphic VT, कि जो QRS complex है वो बीट टू बीट डिफरेंस प्रेफर करे, कभी एलबीबी है कभी आरबीबी है. सो polymorphic VT is called as when the QRS from VT to VT differs in the same patient. Then there is a torsade de pointes. Torsade de pointes happens, as you know, that when there is a the premature ventricular complex or falls on the T wave, then you develop a torsades de pointes. Then the other thing is a bidirectional VT, that the axis from the right to left. So there are only 2 type of complexes are there. It is not it is not mono, but it is a bidirectional. There are 2 type of complexes. It is called as a bidirectional VT. So these are the main 4 types of there: monomorphic VT, polymorphic VT, torsades, and bidirectional VT. Now the monomorphic VT, जिसमें QRS complex same तरह के होते हैं, that is basically a non-sustained, कि थोड़ी देर के लिए आया for 4 to 5 bits and then it goes. Then it's called a sustained, when it continues, and then is an incessant, that it is just continues for hours, and then is a VT storm, which I have told you by definition what is a VT storm. So these are the type of ventricular tachycardias are there. Now, but by far the most important cause is coronary artery disease. It is the most common etiology associated with ventricular tachycardia in structural heart disease. So in the structural heart disease, the CAD, that is coronary heart disease, cardiomyopathies like DCMP, hypertrophic cardiomyopathy or ARVCs, then inherited arrhythmia syndrome like long QT syndrome, CPVT, etc., valvular heart disease, and others. So these are the primary causes of the ventricular tachycardia. Now, suppose a patient comes to you with ventricular tachycardia, or the patient is having, on the ECG, you find that 4 or 5 complexes of ventricular ectopy beats are there. Then what are you going to do? So first and foremost is that you are going to ask the patient history, and you have to ask whether there is any prior diagnosis of structural heart disease, like patient was having any CAD, patient was having valvular heart disease, patient was having any type of heart problem. So you have to ask for that thing, and then you have to go for the risk factor. Then patient is having diabetes or hypertension, etc. Then symptoms of structural heart disease, then known cardiac disorders that may affect the heart, like syncope, attacks, family history, etc. Physical examination should be done. Then the first and foremost investigation to be done is the ECG. ECG is such a important and simple thing which you should always carry out. It is a baseline toilet ECG should be done, and at rest also, and during ventricular tachycardia also. Then there is a 24-hour Holter. If you are not able to, then you should always ask the patient to get a Holter done, which is available to us, round the clock. Then echo is a must in this patient. We should always get an echocardiography, because there are so many things like scarring, like any valvular heart disease, any CAD, we can detect it through the echocardiogram. And also ARVC, there is one arrhythmogenic right ventricular cardiomyopathy, etc. Or hypertrophic cardiomyopathy. So all these disorders, we can structural heart disease, we can detect easily with the echocardiogram. Then in some patients we require accessory testing or coronary angiography also. Then after doing that thing, If the basic evaluation is normal or no structural heart disease is there, then you have to go for advanced imaging like MRI, etc. But if the structural heart disease is there, then also, then there is structural heart disease, then you may have to sometimes do for that. Now, coming on to the ventricular tachycardia etiology. Now, the patient presents with ventricular tachycardia. The first thing is that patient is having structurally normal heart. Suppose we do the echocardiogram sector, the patient is heart is normal. Then what is the cause of this VT? Then we call it as idiopathic VT. So idiopathic VT can be of three types. One is an outflow tract VT, fascicular VT, or papillary muscle VT. So that is this depends upon that the VT is arising from where. Sometimes it is arising from the LV outflow or RV outflow. Sometimes happening from the vascular, fascicles, and sometimes papillary muscle. So these are the three types of the VT in idiopathic VT. The other is a primary arrhythmogenic syndrome. Suppose the patient may be having a Brugada syndrome, long QT syndrome, short QT syndrome, CQT. So I think on the WhatsApp you have seen so many images like a football player. He was playing football and suddenly he complains of this chest heaviness, and then he sits down and he was having ventricular tachycardia. So these are those patients who are actually having genetically Brugada syndrome or long QT syndrome, and suddenly whenever there is some stress like in the form of playing a football or a high risk sports, then he develops ventricular tachycardia. So these are called as the primary arrhythmic syndromes, and they are basically genetic. And the other thing is, if there is no if the patient having structural heart disease, then it may be ischemic cardiomyopathy. As you can see, DCMP, the last patient which we discussed is dilated cardiomyopathy. So like those patients who are having VT, and then there is an non-ischemic cardiomyopathy in the form ARVC, hypertrophic cardiomyopathy, etc. Chagas disease, cardiomyopathy. These can have ventricular death. So this is a broad classification of ventricular tachycardia etiology. Now, how will you manage your ventricular tachycardia? What is the armamentarium? What are the armamentarium which you have for the ventricular tachycardia? The first and foremost is, of course, the medical therapy. Like we give amiodarone, LIGO, IV lignocaine, etc. So medical therapy is one of the most important things. The other thing is the ablation therapy, like doing a catheter or surgery for that thing. And the other is a device therapy, like ICD, defibrillator. We do it. So these are the three armamentarium basically. But the first and foremost is the medical therapy, and especially because most of there are physicians are there, I think the medical therapy is one of the things we should concentrate on that. And then of course the people who are working in the ICU, they have seen that and some of my whenever they ask me that the patient is having VT, so I always ask them what is the potassium. So this is an important thing, that the correction of the reversal cause is a must. Suppose the patient is having a hyperkalemia or hypokalemia, you have to correct that. Patient is having a low magnesium, then you have to correct it. And then ischemia is to be corrected. And like we normally give nitroglycerin, etc. for these patients, or we might have to sometimes give aspirin, etc. So we have to correct the ischemia, and if there is fluid overload, then we have to give diuretic, etc. So one has to correct all these reversible causes, and most of the time, actually, these are the main causes actually. And by reverting it, that you are able to stop the VT storm. And then early pharmacological sympathetic blockade is one thing, and then deep sedation or intubation of GAs can be done in some situations, and especially in the VT storm. Then of course the antiarrhythmic drugs like Calderon, and we will be talking about the Mexiletine shortly. And then the reprogramming the ICD to minimize shocks, neuroaxial modulation, catheter ablation are one of the surgical treatments are there. Now, the therapeutic strategies in the management of VT is basically the antiarrhythmic drugs, which is called as AADs. It is the first line of management of the VT, and the advantages are that it is inexpensive, it's a rapid effect, and decrease in the frequency of ICD shock. So, any patient who are going for the ICD also, they has to be given antiarrhythmic because we don't want ICD should be shocking again and again. So for that thing, antiarrhythmic drug is a must for that patient. And but there are disadvantages in the form of that there may be some contraindication side effects of the antiarrhythmic drugs are there, and of course they have to use lifelong. And then ICD is one thing which is used for the secondary prevention of VT and for non-ischemic cardiomyopathy also. It has a mortality benefit, but it does not prevent the VT. After ICD also the VT can happen. So prevention of VT will definitely lie on the antiarrhythmic drugs. Then there are catheter ablations. It is being used especially for the scar VT is there. So we'll be talking about the medicine part. It is an antiarrhythmia drugs. It was a from the MBBS days we know about this thing. the Vaughan-Williams classification was there, and they classified the antiarrhythmic drugs into that class 1, 2, 3, and 4, and then the others. And the class 1 has three components: 1A, 1B, and 1C. The 1A was actually, the first group is the sodium channel blocker, and 1A is quinidine, procainamide, disopyramide. 1B is lidocaine, mexiletine, and tocainamide. So this is the 1B. Lidocaine and mexiletine comes, and then 1C is flecainide, propofol, morphine, etc. are there. And lidocaine, mexiletine is mainly used in the post-MI VT, idiopathic, whereas the flecainide and propofol is used for the paroxysmal atrial fibrillation, that is supraventricular, mainly supraventricular or a sustained ventricular tachycardia. In the class 2, it comes the beta blockers actually, and as you know that beta blockers are used for sinus tachycardia or for AV or sinus, reentrant tachycardias. Then in the third group, it comes the potassium channel blockers. Among that, the most popular drug is amiodarone, and sotalol is one of the also drugs which is used, and diphthylide and vitulide are the drugs, and they are used for both ventricular and supraventricular arrhythmias. In the class 4, it comes as calcium channel blockers in the form of diltiazem and verapamil. They are primarily used for the paroxysmal supraventricular tachycardia like AVRT, AVNRT, etc., and atrial fibrillation. And the others, among the others, comes the adenosine, digoxin, and magnesium sulfate, which are also used for supraventricular arrhythmias and atrial fibrillation. So these are the broader classification of the Vaughan-Williams classification, which clearly, have a sodium channel blockers, beta blockers, potassium channel blockers, calcium channel blockers, and others. So how and uh, so among the pharmacological characteristics of the antiarrhythmic drugs for the treatment of ventricular arrhythmias, the first and foremost is amiodarone. All of my colleagues, who are working in ICU, they always call me up. That is, whenever I call them that start amiodarone, so they always ask me the dose. So what is the dose of amiodarone? The amiodarone dose is that you are to give 300 milligram of bolus intravenously, slowly over 10 minutes for ventricular fibrillation of pulse plus VT arrest. And then, but if the patient is stable, you can just give a low dose also, 150 milligram bolus. And after that, you are to start an infusion of 1 milligram per minute for 6 hours. And then you have to reduce the dose to 0.5 milligram per minute over 18 hours. The target is to achieve 900 milligram over 24 hours. But in the first 6 hours, you have to increase your infusion to twice that, and after that you have to decrease your infusion to half of that. So this is the basic thing as far as the IV infusion is concerned. And as far as the oral is concerned, suppose you are sometimes we also start with the oral drug also, then you have to give 400 milligram. That normally I take Odronex, like type of drug. So 200 milligram, 2 tablets or 3 tablets, 2 tablets twice daily or thrice daily for about 1 to 2 weeks, and then 300 to 400 milligram, and reduce the dose to 200 milligram daily if possible. So this is the dose of amiodarone. I think you should always remember this dose, and it is used for the ventricular tachycardia of ventricular fibrillation. And the target is to use so the problem with the is that it causes sinus node slowed, QRS is prolonged, QTC is prolonged, so these things can happen. The other drug is the lidocaine. This has been used very commonly in the ICU settings. The dose is 1 milligram per kilogram bolus. So suppose the patient is having 70 kg, then you have to give 70 milligram of that. And then the maintenance dose is infusion, we have to give it for 1 to 3 milligram per minute. So this is what it is. It is used mainly for the VT or VEF. Then the other drug is a metoprolol, which is and beta blockers, class 2 drugs. So the IV is like 5 milligram over 5 minutes, up to 3 doses can be given. Then the drug is mexiletine. So mexiletine is the dose which we are discussing today, and the 150 to 300 milligram 8 hourly or 12 hourly is given. And mexiletine is almost equivalent to the IV lignocaine. So mexiletine is basically the oral congener of the lignocaine. And then procainamide and sotalol are given also for that thing. So let us talk about mexiletine. So mexiletine is one drug which is now available in the Indian market, and mexiletine is approved in the ventricular arrhythmias, and the US FDA has approved it for the treatment of ventricular arrhythmias, and by DCGI also, that is the drug controller in India. The indications for using mexiletine are that the existing or antecedent ventricular arrhythmias and ectopic beats, such as those found after MI and ischemic heart disease, and for arrhythmias induced by the drugs, and for idiopathic arrhythmic effects. So after MI, if the patient is having persistent ventricular arrhythmia or ischemic heart disease, then mexiletine can be used. And there are also ACC guidelines are there, and Heart Rhythm Society. guidelines are there for the use of mexiletine in the treatment of ventricular tachycardia. So the 2017 guidelines clearly show that mexiletine is amongst the recommended antiarrhythmic agents to prevent or treat ventricular tachyarrhythmias or ventricular fibrillation. So this is one of the approved drugs for ventricular tachyarrhythmias. Mexiletine is amongst the recommended AADs in patients suffering from symptomatic non-sustained ventricular tachycardias, and mexiletine is also the drug for the structural heart disease and recurrent monomorphic ventricular tachycardia in addition to isolated ablation. That is from the 2014 EHRA guidelines. So what does mexiletine do? As I just told you that mexiletine is a class 1B antiarrhythmic agent, that is a sodium channel blocker, and it is structurally similar to lidocaine, but it is orally active. So basically, mexiletine is no difficult drug to remember. It is basically the oral variant of lidocaine. It behaves like that. It's not a lidocaine, but it behaves like that. But the problem with the lidocaine is that it has to be given in the IV form only, and it can be given only in the ICU setting. But mexiletine is an oral variant of that thing, which can be given on the OPD basis. So that is how the things are there. So what does it do? It does the inhibits the inward sodium ion current, reducing the phase zero. As you can remember, these are from our physiology days. In the first prof, that this is the phase zero, this is phase one, this is phase two, 3, and 4. So this is the effective refractory period, and this is the relative refractory period, etc. is there, and this is the action potential duration, which we call it as. So what does it mexiletine do? That it inhibits the sodium ion current. As you know that the phase zero is due to the sodium ion current. So it delays that sodium ion current and thereby prolongs that thing. And the site of action is mainly the Purkinje fibers. And though ERP decreased, results in increase in the ERP APD ratio. So that is how the mexiletine acts. So as you told you that it is basically an oral variant of lidocaine, oral congener of lidocaine, and the electrophysiological severity are similar to the lidocaine. In a patient with a normal conduction system, it has a minimal effect on the cardiac impulse generation, no development of second heart rate, and no prolongation of ventricular declaration or the repletion. So what that means is that if you give mexiletine to a normal patient, you know, it does not going to cause any problems, because it is not going to cause second degree AV block, third degree. So you don't have to worry about that thing. It is not going to harm the patient, even a normal patient, if it is given. But if the patient is already having a like a ventricular tachycardia, it will prevent that thing. So patient pre-existing conduction defects, depression sinus node can be there, function sinus node recovery time can be there, etc. And as you can see that mexiletine has a minimal effect on the physiology, unlike the other AEDs. So you can see the mexiletine does not affect the SA nodal rate, it does not affect the AV nodal refractory period, it does not prolong the PR interval, it does not prolong the QR duration, it does not prolong the QT interval. So it has a neutral effect, and so as compared to the amiodarone, which decreases the SA sinus nodal rate, it increases the AV refractory period. So there are chances of getting AV blocks. There is a chances of getting a QT prolongation is there with the amiodarone. But as far as mexiletine concerned, these are no such side effects. So it is one of the safest drugs, just like lidocaine, as compared to the amiodarone. And mexiletine also having no significant on the hemodynamics also. The hemodynamics are very small, usually not significant, and it has no significant negative inotropic effect. So it can be given safely in your direct cardiomyopathy patients, because we've seen in DCMP patients, they have a they already the ejection fraction is low, so the amiodarone etc. drugs can actually decrease the ejection fraction. But mexiletine has no such effect, and it doesn't have any negative inotropic effect. The BP and the pulse rate remains essentially unchanged. So that's an important thing, because with the amiodarone and with the ibuprofen etc. we can see that the pulse rate is decreased, BP is decreased, but with mexiletine it doesn't happen, and there can mild depression, myocardial function may be there, similar to the product of the lidocaine. So these are the pharmacokinetics, and it is well absorbed from the GI tract 90% of the time, and the peak blood levels are reached within 2 to 3 hours only. And the distribution is 50-60% of the plasma protein bound. And unlike lidocaine, its first part metabolism is low. Actually, why the lidocaine can't be used orally, because the first pass metabolism is very high. So it is practically it has to be an IV. But with mexiletine, the first pass metabolism is low, and that's why it can be used orally. And then approximately 10% of the is unchanged by the kidneys. And in normal subjects, plasma elevation half-life is probably 10 to 12 hours. That is why it has to be given in the BD or TDS dose. So the dosage of it is available in the capsule form. The dosage must be utilized on the basis of response and tolerance. It is administered with the food or antacid is recommended. and initiate with 200 milligram every 8 hours. So when rapid control of arrhythmia is not essential. So suppose when the arrhythmias we just are giving for the NSVT, like non-sustained ventricular tachycardia, then you can initiate with a small dose of 200 milligram thrice daily every 8 hours. And the minimum 2 to 3 days between dose limits is recommended, and the dose registered by 50 to 100 milligram increments up or down. So you can increase by 50 milligram every 2 to 3 days or decrease it. And this is the dosage regime. That is when there is a rapid control for tachyarrhythmia is essential, then you give a loading dose of 400 milligram. After 8 hours, you give 200 milligram and continue as per the chronic treatment. Whereas when rapid control tachyarrhythmia is not essential, you give it 200 milligram every 8 hours and 300 milligram every 8 hours, increase of 400 milligram every 8 hours can be given to. So maximum dose is 400 milligram thrice daily. And is there any contraindication? Yes, there are some contraindications that we shouldn't give a cardiogenic shock or pre-existing second degree AV block or third degree AV block, and if no pacemaker is present. But if the pacemaker is already there, then you can give it Mexiletine. What are the adverse, simple, GI effects and nervous system effects are there. That is upper GS distress, maybe sometimes there. That's why you should give it with antacid or with the food. Lightheadedness can be there. Tremor and coordination difficulties might be there. And these are many more sustained ventricular tachycardia. I will not go into the much detail about that thing. So summary, Mexiletine is an antiarrhythmic drug. It is indicated in sustained ventricular tachyarrhythmias. Agent with moderate potency is there. The important thing is that it is safe in LV dysfunction. It is safe in QT prolongation, which is not the case with the myotron. It is reversible, non-lethal adverse effect. So when you stop Mexiletine, the effect goes. It is a class 2 recommendation by the guidelines, the management of ventricular tachycardia, and can be used as an add-on drug to myotron. So patient is already taking myotron, you can add Mexiletine. If patient is taking beta blocker, you can add Mexiletine. So it is an add-on drug, and also if patients can be this drug can be given in ICD patients also. So in summary, the management of ventricular tachycardia involves three major modalities, like a medical, device and ablation, and very often hybrid therapy is required. And VTs can be challenged and need to be utilized. In structural heart disease and highly risk polymorphic VT, ICD is of course the first line therapy. Catheter ablation can be considered for early recurrent symptomatic VTs, and medical therapy is acceptable for minimal symptomatic VTs and low risk subgroup of the polymorphic VT. So thank you very much. So any questions now we can take it up.
We request all the participants, if in case there is any question or query, kindly write down onto the chat box.
So I think ventricular tachycardia is this is one thing actually. This is one type of the arrhythmias actually. We are talking so many about the hypertension, diabetic, etc. But I think this is one of the important things. Especially in the ICU setting, and the people are coming with the like palpitations and having some ECG showing some ventricular topic bits. We should always evaluate these patients, and there has been cases of sudden cardiac death happening. And like which we yesterday only there was a very young died actually. It was saying that normally what happens is that it is the cause is never the MI as such. Post MI there is ventricular arrhythmias, there is ventricular tachycardia sector is happening, and that's why they lead to sudden cardiac death for these patients. So ventricular arrhythmias are a very important thing, and one should actually take it seriously and get a Holter done, etc., and treat it accordingly. So and now we have Mexiletine receptor drugs which are there in armamentarium, which we can start, and we can prevent this recurrent ventricular tachycardias. So I think today's talk will help you in understanding ventricular tachycardia. So I think we can have more meetings in future also, so that we can discuss more cases like that thing, challenging cases. And I would like to thank all the participants who have joined. In fact, so if you have any questions, you can always contact me. So I think there are a few questions. I will talk. Do the treatment remains same for ventricular tachycardia and ventricular fibrillation? Yes, actually, in fact, the ventricular fibrillation, one thing we should always understand is that whether it's a VT or ventricular fibrillation, if there is a BP fall is there, then the treatment, the treatment is DC cardioversion is there. If the BP is less or patient is not having any blood pressure, and the drugs are to be given afterwards, because these patients are prone to get a repeated episode of ventricular or ventricular fibrillation. That is why the drugs come in that scenario. So to prevent that the patient is having a recurrent ventricular tachycardia or ventricular fibrillation, then we have to see. Yes, the treatment largely remains the same for ventricular and ventricular fibrillation, but most of the time ventricular fibrillation patient will need a DC shock initially, and then afterwards we have to go for the ICD, and along with that, before ICD, we have to stabilize, we have to maintain that the patient doesn't develop recurrent VTs, and that's why the role of drugs come in that scenario. So, sir, in clinical settings, is beta blocker better? Yeah, definitely. Beta blocker is a drug of choice always. We for any tachyarrhythmias, beta blockers has to be on board. Ventricular tachycardia drugs like amiodarone or mexiletine, etc. They are add-on drugs. In fact, sometimes the beta blockers are definitely very, very good for the supraventricular arrhythmias, but for ventricular arrhythmias also, especially these cardiac, the beta blockers definitely have a good role, especially if the BP is favorable. But along with that, but the beta blockers alone sometimes doesn't work too well, especially in the ventricular arrhythmias, and that is why we have to add like drugs like amiodarone and mexiletine for that thing. Yeah.
Anyone want to ask any other question? I feel, sir, you have handled all the queries. It was so nicely explained by you, sir. So, if you permit me, can I close down the session, sir?
Yeah, sure. No,
Yeah.
yeah.
So, thank you, Dr. Sanjeev, for joining with us today. It was really an insightful discussion for us as well as for our listener. I would also like to thank all the doctors for being with us and for their active participation during the session. Thank you all and have a nice day. Thank you, Dr. Sanjeev, for joining us today.
Thank you.
Thank you, sir. One question is being not answered of Dr. Gupta. Dr. Gupta, we will get back to you since sir has left the meeting. We have noted down your query, sir, and we will give you an answer, sir. If possible, sir, can you please share your contact number with us?